Assalamu alaikum, dear APPNA family. We are here again, Ask the Experts #2 webinar. This is our continued effort to keep our members and local communities informed war against coronavirus. APPNA is a professional 501(c) organization of expatriate physicians of Pakistani descent. APPNA has been in the forefront in this critical time by raising funds, providing food for poor, securing PPE for fellow physicians in Pakistan and USA, and arranging webinars are some of the efforts through its various committees. Today's webinar is meant to provide important information to general public by our experts and to answer some questions which may help in saving lives and keeping people safe from viral infection. Let me introduce our guest and panelists. We have Dr. Aisha Zafar, who is the chair, Social Welfare and Disaster Relief Committee. We have Dr. Sajid Chaudhry, who is the chair, Coronavirus Task Force, who himself is an infectious disease specialist. And in addition to treating his COVID-19 patient, is in the forefront and is spending enormous amount of time helping us in a war against coronavirus as well. Our panelists today are Dr. Mobeen Rathore. He's a nominee President-elect American Academy of Pediatrics, which is a great honor not only for Dr. Rathore, but for all of us as well. He's a professor and associate chair, Department of Pediatrics, University of Florida, hospital epidemiologist and chief infectious diseases and immunology, Wolfson Children's Hospital, chair Baptist Health System Infection Prevention and Control Committee, founding director, University of Florida Center for HIV/AIDS Research, Education, and Service. Dr. Avais Masood is a board certified in critical care medicine and nephrology. He's a program director, nephrology, critical care nephrology fellowship at Jersey Shore University Medical Center, New Jersey. Assistant professor of medicine, Seton Hall University School of Medicine, also New Jersey. Our third panelist is Dr. Muhammad Raza Khalid. He's a board certified in infectious diseases and critical care medicine, consultant infectious disease, Southlake Regional Health Center, Newmarket, Ontario, Canada. So first of all, I'm going to ask our guest to give us a little update on all the efforts which APPNA has undertaken with regard to the coronavirus fight. I'm going to ask Dr. Sajid Chaudhry and Dr. Aisha Zafar to please give us an update.
Assalamu alaikum. First of all, I would like to thank the APPNA Executive Committee for trusting us, me and Dr. Aisha Zafar, and giving us the responsibility to handle and tackle with the coronavirus pandemic efforts of APPNA. APPNA task was created almost immediately after the pandemic was declared, and we started fundraising within like 48 hours. Initially, the APPNA Task Force Welfare Committee, as well as the Executive Committee and BOT, they pledged $20,000 immediately for this fundraising. And then within 48 hours, we reached our first target of $100,000. When we were trying to look into the options that how can we participate and help people, first thing was the food distribution, because the people were staying at home. And at that time, we partnered with ICNA Relief USA. And I will request Dr. Aisha Zafar to give her comments and input about the partnership with ICNA Relief USA.
Thank you, Sajid. First of all, I want to recognize the fact that together as a team, we have worked very well working with the task force which was created for COVID-19 and SWDRC. So the initial focus that we had was basically on food, as our concern was that that is probably going to be the biggest requirement at this time. over the last 10 days, as you know, things have changed and we are now kind of focusing more on PPE. However, as far as the food is concerned, we partnered with ICNA Relief, which has turned out to be an excellent project so far. What we are doing is that we are encouraging chapters and alumni that anyone who gives us $5,000, we will match it with $2,000. We actually, luckily, have had 2 or 3 donors who have stepped forward. They want to remain anonymous, but they have requested that anyone who's giving food, anyone who's giving $5,000 will be given a match for $2,000. So far, the cities where we have distributed food, as you know, New York City has been very badly affected, New Jersey, we have given food in Seattle, in Dallas, New Orleans. It's also being done in Philadelphia at this time. So that is the initial thing. There are some chapters have wanted to work with the local food pantries. Even if that is the case, we are still going to match the funds for that. However, per the donor's request, it was for ICNA where the matching was for $2,000, and for other pantries, it's going to be for $1,000. So that is basically as far as the food projects at USA is concerned. So I'll let Dr. Sajid Chaudhary give the rest of the feedback.
Other aspect was to provide the personal protective equipment to healthcare professionals, which we started in Pakistan initially. First 1,000 KN95 and 1,000 of N95 masks has been ordered, and actually it has been delivered in Pakistan. Shipment is there, and they will get by Monday. Next shipment of 5,000 masks of KN95 and 5,000 of N95 has already been ordered for that. As it is affecting areas in USA. So in the New York, the first shipment of 200 masks of KN95 and 500 masks, surgical masks, have been already delivered, shipped to Elmhurst Hospital, which was badly hit by Corona infection. We have also placed order of 5,000 masks of N95 and 6,000 of N95 to be delivered to USA. We'll get it next week. We will start distributing those masks. We have also obtained generous donation from a generous donor, and will be placing order on Monday about $10,000 of face shields, 10,000 of protective gowns, and about $200,000 worth of KN95 masks. I will request Aisha to give us some little bit more information about that donation.
Okay. So, you know, we are extremely fortunate that we have very generous donors, and these are actually, some of these are non-APPNA members. The donor actually is Mr. Asher Aziz, who is from the Silicon Valley. He contacted APPNA, and his initial concern was about providing for food. However, we had a very long discussion with him, and he was concerned about the current status of PPE, both in USA and in Pakistan. So Mr. Aziz has been very kind enough. He has come forward. He'll be giving us a donation for $300,000, which will basically be for protective gear. Again, our concern at this time is that the requirement is so huge. In the last 48 hours, I have had, I think, over probably 30 hospitals which have contacted me asking for this. So what we are going to do at this point is that any chapter or any individual or any alumni that raises any amount, we are going to match dollar to dollar. So if someone is going to raise $3,000, we will give $6,000 so that we are able to provide PPE worth that amount. I do want to mention that it has been a challenge to get this equipment from overseas. At this time, the only place where we can get this equipment is really from China, and there's a huge backlog. We're very fortunate that we are working with Mr. Amir Farouk, who actually initially donated. This is his private business, and he's a vendor, and he's been very kind. He actually donated about 700 masks, which were given to Elmhurst Hospital, which was very badly affected. He's also sending masks to Pakistan. But we have to realize that despite the huge number of requests that we are getting, we're trying our best, but I don't want to tell, someone called me this afternoon, they wanted the masks tomorrow, and you know, that's just not possible. But I do feel that with this donation, and especially if we have people who will be willing to give so that we can match these funds, I think we can achieve quite a bit. So I'm very grateful to Mr. Ashar Aziz, and his brother is Dr. Bhatt, who is in Brooklyn Hospital. They're both guiding us on how to deliver or which hospitals to work with as far as the PP is concerned. And just one other thing I didn't mention before, the food which has been given to APPNA Food Pantry so far, we have given them funds for $23,000, and we have another $12,000 through this weekend, which came in through pledges and donors. So I will let Dr. Sajid Chaudhry give the rest of the update.
Ajit, so next step is to provide the PPEs and food in the far-flung areas of Pakistan, including rural Balochistan, Gilgit, Azad Kashmir, and southern Punjab. Fortunately, we have partnered with Helping Hand. They will be our partners on the ground, supplying the PPEs and the food to those areas. We have also partnered with the Human Development Foundation of North America, HDF, and they will be supplying food to the some rural areas of the Balochistan. I will request Dr. Aisha, she actually communicated, she has been working diligently, non-stop, contacting with all the donors and the NGOs to coordinate the effort. So Aisha, can you please give your comments, input about your communication with the Helping Hand?
So, you know, again, this is, I know these are difficult times. They're very challenging times for physicians and for the families, and obviously for all the patients that are being seen. I have been getting calls from Skardu and from Gilgit area, which has been, as you know, there were a lot of pilgrims who had gone to and came back. Most of them were in this area. They tested, they're COVID-19 positive. They were asked to stay in isolation, and delivery of food was a major issue. There is a group by the name of Rupani Foundation, which is in Houston, and they are delivering Dr. Mohsen Ansari, and then he contacted, he's the president of Helping Hand. They were very generous. I called them this morning and I said, we need about 300 kits, which are to be delivered in Skardu and in Gilgit. And they said, this will be a donation from Helping Hand, and they actually assured that this will get there within the next day or two. I've been in communication with the doctors both in Gilgit and in Skardu for 2 weeks. So this is really a godsend. And I know that aid has been provided by China, but what has happened with that is that it takes a little bit of time, I think, to get it delivered. So this is an excellent partnership. And initially, you know, as we mentioned, we were basically working for food with Selani, and we were working with Ahuat, but now we are also working with other organizations like Al-Khidmat and also with Helping Hands, because there is a bigger outreach some of these organizations have, and also because they have been very quick to respond.
Thank you very much, Harun. We are almost done, and once again, I would like to appreciate the APPNA Executive Committee for all our donors, our volunteers, our committee members who are diligently working with us and coordinating these efforts. Thank you very much. Assalamu alaikum.
Thank you very much. Thank you very much, Aisha and Sajid. You guys are doing an enormous job. It's your dedication is second to none. We really thank you for your hard work. So you are more than welcome to stay, but now we are going to move to our second portion of the program, which is I'm going to give 1 to 2 minutes to each of our panelists to give an opening statement, and then we will go to questions. So first I will ask Dr. Mobeen Rathore to please give an opening statement.
Thank you so much, Arun. I think the most important thing I can state in the beginning is that everything you hear about COVID-19 is probably going to be old by the time this webinar is over. And I would encourage everybody to make sure that they continue to listen to what the CDC and the professional societies are telling us, because this is a very dynamic, fast-moving situation. Things are changing every day. So just keep keep looking up for the updates. We'll talk a little bit about what is known now, and we'd be happy to answer any questions. Thank you.
Dr. Avais Masood.
Yeah, I'm in New Jersey, and which is unfortunately is the epicenter of this infection now. I just came back about half an hour back from hospital, and same situation, a lot of patients with this infection. We'll talk about that, but one thing I would like to say, people who are in Pakistan, please be realistic. I am seeing on Facebook and social media, a lot of misinformation are being spread over there that we'll be protected. Pakistan has less risk as compared to other places. I just want to let you guys know that, let you folks know that, please listen to the people who know about that and don't listen to any, unrealistic, false hopes. So just to follow the direction which everybody knows now, and we'll talk about in this discussion more about that.
Thank you very much. Raza, Khalid.
Assalamu alaikum, everybody. Nice to see some familiar faces now. Unfortunately, there is a lot of misinformation. I agree with Dr. Avais Masood. And there's a lot of, what should I say, cheap talk going on about different things that work. Actually, nothing works right now. We have to be clear on that one thing. Everybody is swearing by something and that it works, but it actually doesn't. There's no randomized control trial, I should say. So that's something that we should all be very clear on, and I think we all know these things.
Very good. Thank you very much. My first question is to Dr. Mobeen Rathore. My question is that why the rate of spread of coronavirus is different at different places, even within one country?
Well, I think the transmission rate of coronavirus based on studies, which is really something which is called the RO factor, R0 factor is about 2.8, anywhere from 1.5 to 2.8. So it's about double what the variation could be anywhere in that. So the contagiousness is the same. What you're talking about is how different areas are having various levels of spread of infection, and that has to do a lot more with how the areas and the regions and the countries are responding, how fast, and social distancing and other important preventive measures. And it's not necessarily that the infectiousness or contagiousness of coronavirus is different in different parts of the country or different parts of the world. The virus does not know that difference. Its contagiousness is the same. It's just how we are responding to it that's affecting how the virus is spreading in communities.
Well, thank you. Actually, since I have you, there is another question which is about epidemiology. So I'm going to ask Dr. Mobeen Rathore again. The question is, once it hits the peak, which when the CDC and all other places are showing the curve, and they're saying that once it hit the peak, when we should expect the life to get back to normal? Is there a time frame?
Yeah, I think that's a very challenging question because we don't forget that this is only a 4-month-old virus and we are still learning about it. But there are some models, different universities, different institutions have modeling done, and the modeling, as you know, depends on the data that's input into the model. Most models are predicting that the peak of this epidemic in the United States is going to be about 4th of May or around that time. The China model from Penn and the Johns Hopkins model, I think the London model, England model is a little bit different, but that is just a model. And from now till May 5th, we'll have a lot more information, a lot more data, so that we may be fine-tuned and changed. But once we hit that peak, what I've been telling people, and this is not based on a lot of science, this is based on just conjecture and speculation, it's going to take as much time to get back to normal as it took us to go to that peak. So if anybody is telling you that they know how long it'll take before we are out of the epidemic and we are at the stage where we were before the epidemic started in the United States, I think you should question that. But I think it's fair to say, at least if you look at historically the pandemic, the Spanish flu pandemic in 1918, if you look at that's what happened. It took as much time for it to go, about the same amount of time for it to come back as it took for it to reach its peak. But don't forget, once it comes back, it's going to be smoldering on for a period of time. It's not, it's not like the epidemic started from nothing and peaked, and then it'll go down to sort of a reasonable, well, I'm not sure if the word is reasonable, to a certain background level, and then it'll smolder over a period of time. So I expect if it's May and started 4 months, I'm telling people plan for July, August. I know most of the politicians are saying June, but that's what I'm telling people and friends who ask me.
Okay, thank you very much. So we have Abdul Hamid, who is online and has asked a question. His question is, using mask, is this mandatory now everyone to wear? Before it was said only for affected persons. This is for Dr. Avais Masood.
Yes, actually, we are learning more about this disease, how to prevent the spread of this disease. And every week we have a new knowledge. And our latest knowledge and the CDC recommendations are that every person who should wear his or her face or nose, or mouth to prevent the spread of this infection. The reason being that it has been found that a person can spread this virus even by talking or even by breathing. So that's the reason that the new recommendations are. Recommendations are that people who are non-medical field person, who are not in hospital, nurses or doctors, they should wear like their common use things to cover their faces, like anything which can cover their face. Don't use a surgical mask for normal use, because leave it that for doctors, nurses, and the other medical staff people. So this is actually more learning. Actually, the only thing which have proven to, as Dr. Rathore said, proven to prevent the infection is, social distancing, and and also prevent the spread. And one of them, very important factor, is the cover your face, nose, and mouth by any cloth you can found.
So there is a role of just cloth mask made in homes. People should wear those.
Yes, exactly. They should wear that, like very simple. Like people used to wear it like any kind of muffler they call in Pakistan, or anything which can cover. Don't have to be like a medical mask. Anything can prevent from spreading their whatever comes out from their mouth and nose by breathing or coughing or sneezing. That would be a big help in preventing this spread.
So Avais, this question is also to you. It's Dr. Taj Khan is asking this question. Any role of air conditioning system in American homes in spreading virus through air conditioning ducts if one person is infected or visit that home?
Actually, very interesting question. I didn't see any recommendation regarding that. Actually, I was other day I was thinking because I was in my office in the hospital and there was like a heater going on, circulating. So I think actually depends on the air condition in that case, because air condition, when they circulate, they bring the fresh air from outside. Actually, might be helpful, but again, that's I can or even you open your window from outside and that just bring the fresh air in. But if the air is stuck there in the same room and it's not good ventilation, that actually will not be very helpful in preventing that spread. So if you go to somebody's home, I think air condition should be helpful in that case.
Very good. This question is to Raza Khalid. If I have a mild symptoms, do I need to go to the hospital or can I stay home?
Well, the recommendation is very clear. If you have mild symptoms, you don't have to go anywhere. You can stay at home and weather it out until and unless it gets worse. And the recommendations are very clear that if you get short of breath, then you really do have to go. So that's only one criteria.
So Raza, in early stages of infection, is it possible that the test may be negative?
Well, it's a PCR test. So PCR tests are always very, very sensitive. So it's hard for me to believe that it would be negative. I don't know the exact figure, how many are negative in early and you are infected. I think we have the serology test that's approved now. I think that will be the real one. That will tell us actually how many people had it and actually did not have any symptoms.
So let me add one thing.
Harun?
Yes.
If I may add, I think the challenge with the test is, as you know, as it was mentioned, it is a PCR test. So you need virus particles. And what happens that during the incubation period, you may not have enough on the specimen that is gathered. I mean, if you could gather enough of the virus, because as you know, during the incubation period and also in early asymptomatic illness, the viral load in the secretions may not be that high. But that could potentially give you a false, if you will, a false negative. The test is very specific and is very sensitive if you have the virus. I think that's something that has been discussed about the molecular test. One other thing I want to mention, I was trying to answer a question from somebody and I messed it up. They asked about reinfection. The best of our knowledge, there is no evidence of reinfection right now. In the current season, we don't know what will happen in the future season. So if you have had COVID-19, you should be considered immune. I think that's what's being recommended to most people. I apologize, somebody answered, Dilip Kumar asked the question and I inadvertently was not able to answer it.
Okay, actually this question was asked for several other people as well. Excellent that you answered that question.
Let me add.
Yes, go ahead, Avais.
Yeah, actually what happened that in the beginning is some people were negative and they found to have the infection. The most likely reason at that time was found that the technique of taking the sample. Because if you're not taking a sample deep enough in the nose, and that can be a false negative. So that was initially, now people are more trained, but initially it happened to a lot of people.
Okay, so the next question is by Ehtasham. This is to Dr. Rathore. How reliable is CDC? Their current recommendation is to wear masks for all now. Why not earlier part of COVID-19 spread?
So I think you should have great confidence in CDC. I think it's our premier, I think everybody in the world considers the premier organization when it comes to addressing epidemics and pandemics. So I think I have full confidence in CDC. CDC has a tough job. We are asking it for making recommendation when the data are limited. So I think it's very important to keep that in mind. Also, there are several levels the CDC has to do things at. One is, don't forget the scientific, the medical, what needs to happen. The second is equally important, perhaps, is the confidence of the public. Right now, the public is very anxious. We all know, so when you think about the masks, the N95 mask is the best mask, okay? It should prevent at least 95% of the particulate matter, including the virus, to not go through it. The surgical mask is not as good as the N95, but it's still better. And the cloth mask is probably, and it's not even been studied, but if you remember, many of us in Pakistan who graduated, we only had cloth masks for surgery, basically. And what we do know that these masks are probably more efficient in preventing, if you are infected from that virus, to get out of and infect other people. We don't believe it's going to be as effective in preventing you to get an infection from somebody else. So cloth masks are, there's some psychological benefit also, and I think that's important in an epidemic, pandemic situation. So there may be some benefit, but amongst the three masks is probably the least beneficial. So the CDC's role is very tough. We are demanding from CDC action and guidance, and they have to make those decisions based on the limited information they have. Thank you.
Very good.
And I would just add a quick one. I mean,
Sure.
Our experience showed that CDC were also not 100% right on timing-wise, at least, in many of their directions. So this is one of the cases that they should have recommend this, come up with this recommendation soon enough. They did, I think they were late a bit. In hospital also recommendation, many of physicians feel that some of the CDC recommendations came a bit late.
Let me just add one thing. The reason why this mask was added as a for everybody now was because of the asymptomatic person-to-person transmission. It was seen recently in Canada and in New York that the data showed that the person-to-person transmission in asymptomatic people was actually very important. And the secondary attack rate was close to, I think, in some studies, close to 6%, 2 to 6%, this range. So that's the reason why they said that, we have to use the mask, because if you're asymptomatic, you can spread it to others.
Very good. So we have Ahtasham who wants to ask a question. I'm going to see if I can allow him to talk directly. Ahtasham, can you hear us?
Can you hear me?
Yes, we can hear you. Go ahead with your question.
Thank you. Thank you very much. I really appreciate that. Thank you, Dr. Rathore and Dr. I believe CDC is the most reliable organization in this country, but I do agree with Dr. Avais. They were late. They made a mistake. I think CDC on a higher level should apologize to all people in the United States that their recommendation for masks late. And that's the comment I want to make. If anybody has a connection, I know Dr. Anthony Fauci has a connection with UAB also, where I'm clinical professor. I'm taking this issue also late. That's what I want to make a point. Thank you.
Thank you very much. So my next question is to Avais. If I have a fever or sore throat or other symptoms, how do I know it is time to call my doctor or go to the hospital?
The one thing is very important. That is a shortness of breath. Okay, and if you otherwise have no past medical history, you are otherwise healthy, and you have sore throat and fever, and you are not short of breath, you can wait. Isolate yourself if you can for a few days and see how you feel. If things are getting worse, your sore throat is getting worse, fever not coming down, and on top of that, you feel like you're getting short of breath, that's definitely a time to call your doctor, or even before that, when it comes shortness of breath, that's most likely time to go to hospital. But if you just have sore throat or fever, but no shortness of breath, you should wait a few days and see how it goes. If you have some other condition causing that, you expect to improve in next few days.
Okay, thank you. This question is to Raza Khalid. Actually, there's Imran Bhutta who asked a question about reinfection, which has already been answered, and this is a question from him as well. How do I know when it is safe to discontinue home isolation?
Yes, it's this home isolation discontinuation, there's a very set recommendation about it. It depends whether you have the testing available or not. If you do not have the testing available, usually from the start of symptoms, it's about that the fever should not be there for minimum of 3 days, and you should not be taking any medications for that. And cough or shortness of breath should have resolved. So it's either from the start of the symptoms 7 days, or it should be 3 days before all of these symptoms should be gone. So 7 days or 3 days from no fever, no shortness of breath or cough, you can discontinue it. Home isolation.
Okay. Dalip Kumar asked a question on similar lines. Maybe Raza, you can answer that as well. His question is, if repeat COVID test comes positive after 12 days, but symptoms have almost resolved, when should test again be pursued, and for how long further isolation should be maintained? Already 2 weeks isolation completed.
This is a very difficult question. Now, this is a RNA test, right? So you can have your RNA and the test can be positive. Actually, let me first tell you if you have a testing available, you need to have 2 tests negative in 24 hours before you can be declared that you do not have it. But there is a problem between having the infectious virus and having the RNA. The PCR picks up the RNA, but you do not know what's the significance if this patient really has an infectious virus. So what our hospital is doing, that if you are positive, we do still give them, and they're symptomatically okay. What you do is you tell them to have a mask. They can come back to work. I'm talking about healthcare workers. I'm not talking about normal population. They can come to work, provided they do not see immunocompromised patients. They keep the mask for 14 days and they check for worsening of any symptoms. If they have any of these, then they should be taken back. I want to know the opinion of Dr. Avais Masood and Dr. Rathore about this. What is their hospital doing?
Exactly the same policies.
I think you're correct. We are doing the same thing. I think the differentiation that Raza is trying to make is that the infection is by replicating virus, and that you can only have by a culture. The molecular test only looks at the RNA. So even a dead virus, if it has an RNA in there, it will be positive. So that's why you have to match it with symptoms. The difficulty is that if you put in a place that you have 2 negative tests within 24 hours, then you have to follow your policy. And so that's where the challenge comes for returning workers. And we have faced that as some we do know that there was one patient, I believe, who was reported to be shedding 29 days after got an initial infection. So we want to learn a lot more about it.
Okay, I have one comment on this recommendation that how to come out of isolation, that 3 days after your symptoms are gone or 7 days after your symptoms started. This is CDC's recommendation now, but my feeling is that they might change in near future because many people think that that is a bit too early. If you can afford to keep yourself isolated a bit longer, that is even better. Because in other countries, what studies show that the time where isolation should be after an infection a bit longer. I mean, in China, they recommended actually 14 days.
Yes.
Okay.
Actually, WHO says that some people are being recommended to be isolated for up to 21 days, actually.
Yeah.
Okay. So this next question is to Dr. Rathore. Are the symptoms of COVID-19 different in children than in adults?
Well, I think symptoms are similar, except children tend to get a lot more viral infections. So it becomes a little bit of a bigger challenge because they are still getting their usual viral infections that they are supposed to have growing up. Adults get them less. So many times it is a challenge for us to differentiate. And I'm not talking about influenza, I'm talking about all the other viruses, including the regular 4 coronaviruses that are in the community all the time. So that's the biggest challenge. I think otherwise, it's quite similar between adults and children. There may be some differences, but I'm not aware of any specific or particular differences in the 2 reports that came out from China about children. But I said, we're going to learn a lot more about it. What we do know is children tend to get as ill as adults do. In the 2 studies, there was, I think, a small percent of kids who were in critical care, and each of study had only 1 death. So we had 2 deaths with COVID-19 in the United States, but the studies show that kids are not as ill as adults get. And so, but again, the differentiation, at least I don't believe I would be able to differentiate a COVID-19 patient from another viral infection. And I've been doing it for 30 years.
Okay. So the next question is from Dilip Kumar. And the question is, if repeat COVID test comes positive after 12 days. No, actually, he has sent another question. If you just feel pressure in chest and no other symptoms, how do you differentiate it in anxiety due to COVID-19 or you have symptoms of COVID-19? Avais?
I mean, it's very atypical just to have chest pain from COVID-19 anxiety. So obviously, if you have a high risk for that, if you have other conditions which can prone you to develop a cardiac issue, then obviously you have to take it seriously. And if you are young and you're unlikely to have any cardiac issue, then probably anxiety is causing that. But again, anxiety can cause chest pain, but you have some other symptom also with anxiety, like tachycardia or sweating. So, and if you are, it's very hard to say very definitely that it's not any cardiac issue, it's just an anxiety. So it depends upon your presentation and your history. That obviously coronary chest pain has a typical presentation is different, but atypical chest pain also happens, which can sometimes lead to coronary artery condition. So it's very hard to say that, but again, depends upon patient's past medical history and risk factor for coronary artery disease.
Excellent, thank you. Question to Raza. Is well-controlled diabetes and hypertension still a risk factor?
Yes, it is. Even well-controlled diabetes is immunocompromised state. Okay. So you are at a risk.
Okay, so a question on similar line by again Dilip Kumar. Experience regarding use of hydroxychloroquine in mild symptomatic COVID-19 patients?
No, it should not be used in mild symptoms. No, I know I've been under pressure to recommend it.
I would suggest that if somebody is very interested, they should look for one of the trials that's going on and become a part of the study. That not only will that serve good for the general public, but if you are really want it, and of course you don't know if you'd get it or not because these are, but actually they're not all placebo controlled, so there are some. So you should try to access a trial rather than just getting it prescribed to you. Although I know for a fact, and maybe Avais can speak to it, but in New York and New Jersey, they're using hydrochloroquine quite a bit, actually, and my understanding is from my colleagues.
Yes, actually the hydroxychloroquine, we're using almost all the patients who are in hospital. But as Dr. Raza said that, or Khalid said that we are not prescribing for out-of-hospital patients who are mild symptoms, yes. So they are not a candidate for this medication. I just want to tell you one interesting thing. Today, I saw 2 patients admitted to ICU. First time happened over the last 2-3 weeks. Patient, lupus patient, and they were taking hydroxychloroquine or Plaquenil for their lupus. So that did not, prevent them from having this infection. And both are relatively young patient and both end up in ICU.
Very good.
While on hydroxychloroquine.
The next question is, does having regular flu or pneumonia reduce individual risk for developing COVID-19?
No.
That was a very quick answer.
It is very.
Absolutely. No, I agree.
Okay, and the next question is, what should people in higher risk of serious illness with COVID-19 should do differently?
They have high risk and they should how to prevent. They have to be extra cautious about that. That's the only thing. Prevention is the best way to handle this disease because once they have this disease, they will be likely to have, worse consequences. I just can tell you that 4-hour transplant patient who end up in hospital in ICU, none of them survived. One cardiac transplant patient was on immunosuppressant medication. That patient also did not make it. So, but again, we have a large number of patients who are immunocompromised from different conditions. They are almost all of them, with a few exceptions, they are fine because they are just taking care of themselves. They are isolating themselves, so they are fine.
Harun, actually, I have a question for Avais since he's seeing a lot. We have not seen any COVID-19 infection in our HIV patients. We have not in our program, and we have communicated amongst the other providers. So, 10,000 HIV infected patients amongst providers, and we have not seen a single case of COVID-19. That's one of the question. And if you have seen those patients, there is some speculation that they will fare better because they will not have the cytokine storm. So can you comment on those two things?
We have patients with HIV on antiviral medication. They end up in hospital and they end up in ICU and they have a cytokine storm. So I think I can remember like 1 or 2 patients. So maybe out of many, we have few patients, they end up in hospital, but you might be right, they do not have that cytokine storm that much, but we have patients who had this condition, HIV patient on antiviral medications.
Thank you.
Thank you. The next question is there going to be long-term sequela of having kids in isolation out of school and not allowing them to go out? Will there be any psychological issues with those kids, and what should the parents do to minimize those?
Let me take that one, I guess.
Yeah, Dr. Rathore, go ahead.
Yeah, so I think we are very concerned. It must be a pediatrician who asked this question or a family physician. We are very concerned about what's known as adverse childhood events. You know, all of you know that one of the social determinants of health for everybody, but especially for children, are adverse childhood events. And adverse childhood events, in general, I would say, is anything that is different from your normal situation, whether it's stress at home, whether divorce in families, whether abuse, spousal abuse, or drug abuse, whatever. And we believe that this is an adverse childhood event and what we refer to as ACE. And so, yes, these are some things that we will have to deal with. There's also some concern in the American Academy of Pediatrics, and others have come up with some guidelines how you can help children go through this. It is not normal for children to be isolated. In fact, you know, when we had the thing on our southern border with Mexico about children being isolated, you know, that was a huge problem. So it's not a similar situation by any stretch of imagination, but still children being isolated, staying at home. And the other part is we have always recommended that children have very little screen time. And now, not just children, everybody's having a lot of screen time because that's how people are functioning. So I think, yes, adverse childhood event, this is an adverse childhood event. We will probably see some issues coming down. So it's very important that your pediatrician talks to the children, talk to the family, try to answer their question. You know, there's a lot of uncertainty amongst the parents, amongst the healthcare providers. They hear a lot of news, so you need to get them away from the television and social media where they don't have this constant onslaught of information. Unfortunately, much of that is wrong. So I think this is an issue that has to be dealt with, and we do expect, unfortunately, that we will see some issues down the road. But I think as people will tell you, we expect to see issues in the adults also down the road. Nobody in their lifetime has experienced anything like this. You know, let's be honest about it. We are having difficulties. You know, we don't, I mean, I'm a people person. I mean, being alone at home and not going to parties every weekend is sort of a challenge. So I think everybody's going to have some issues.
Very good. This is a question from Dr. Munid Shikari. Unless you want to take this, any updates on management of myocarditis?
I mean, nothing different. There's no new medication or recommendations regarding that. The only thing we doing nowadays that patients who are coming with this infection, COVID-19 infection, and they have acute coronary syndrome, they are slightly less likely to go straight to cath lab. Some of them get TPA, but I think things will change when we have a rapid COVID-19 test. So any person who comes with that, they have a quick check, and if it's negative, he or she will go to cath lab. Otherwise, TPA is not an option. As for the myocarditis is concerned, that is nothing new about that. The only thing that now we are giving heparin or anticoagulation very with that low threshold because this is a thrombogenic condition. Now actually we just decided today that every patient who have D-dimer level of more than 4 times normal should be anticoagulation will be getting a full dose. Myocarditis, there's no treatment, no steroids indication, not even iron drops, just have to watch and see and give just regular treatment to those patients.
Thank you. This question is from Rizwan Khalid. This is for ID people. Do Pakistanis have I think we just touched a little bit on this one, but I think this is a full question. Do Pakistanis have immunity to COVID-19? What is your opinion of BCG vaccine and COVID-19? Malaria endemic areas are less hit. Why? Raza, you want to take this question?
Well, I don't think so. We should live under any false impression or false that we will be protected. Time will tell. I hope it doesn't. I hope it's true, but time will tell. Right now, we cannot make any assumption.
Yeah, I will just add to that. I mean, nothing add, like just same thing. Other day I had an interview in Pakistan TV channel. The only thing I want to emphasize this thing that please don't believe on this because malaria in Iran also they have a lot of malaria, and Irani, but they were not protected. BCG also in many countries, I think in China also including and Iran, BCG, but they were not protected from that. So there's no proof of that, and please don't be in any false hopes.
Okay. So normally the flu season basically ends with when the summer comes. So should we expect any help from hot temperatures? This is a question asked by Abdul Hamid. Dr. Rathore, you want to take this?
I don't know. I don't think anybody does. This is a new virus. We know from the other 4 coronaviruses, they usually don't last in the ones that are the seasonal ones. There are 4 other coronaviruses that we get infections every year, not the novel ones. And every 2 to 4 years, there are outbreaks of that. And they do tend to wither away over the summer. But I'm not sure that we know enough to assume that that will happen. I think it will be really dangerous, in fact, if we think that this virus is going to do what we expect some of the other viruses to. But don't also forget, we do see viral infection in the summer. Enterovirus is a summer fall infection. And so viruses, they tend to do differently. Yes, flu in Florida, we see in the last several years, our flu season went until middle of May. And so I think, I don't know, maybe Wes and Raza know, but I don't know the answer to that.
Actually, if it's going to be winter in our place, it will be summer in the southern hemisphere, and southern hemisphere will have winter when we will be in the summer. So, in the tropic,
right now there's summer in Australia, summer in South America, and they have this infection over there too. Yes. So again, should not very optimistic about that. Only time will tell.
SARS actually virus was there for about, I think, if I'm not wrong, I was in training. It was about around 1 year.
Yeah, it was still at least, I think, 2003 or so.
Yeah, it was 1 year. And Middle Eastern coronavirus, I was in the Middle East. It stayed longer, actually.
Yeah, May, June. And also, I think SARS, I was actually in Toronto in June, and it was still, we're still having SARS issues.
So, modulating based on previous related coronavirus, it tells that it lasts a little bit longer.
Okay. What is going to be the role of vaccination? Is the vaccination we are getting any sooner? I mean, is there a time frame? And will the vaccination be required every year that now we get vaccination for flu?
Yeah, vaccines are not, I think this question gets asked all the time. If we are lucky, vaccine will be available in 18 months, maybe a little less than that, which really means if a vaccine to be effective, it's going to be in the 3rd season. We are probably not going to have the vaccine. And if the expectation is that this is going to be seasonal, and again, we don't know that, but many people are talking about, including Tony Fauci said a couple of times, then the vaccine to have an impact on a season, you have to vaccinate people before the season starts. And if the season starts in the winter, and we are going to talking about 12 to 18 months, the vaccine is not going to be available until the 3rd season. So frankly, I'm not optimistic we'll have the vaccine for the next season. We may get lucky, or maybe a serious breakthrough or something, or a cell-produced vaccine, but it doesn't look like it. Of course, vaccine is our best hope and is the best thing we can do. We have the H1N novel pandemic flu vaccine in the vaccines right now. So, yeah, I think it's something that we hopefully will have, but I'm not very hopeful it'll be before the 3rd season.
Yeah, about vaccine, because vaccine problem is that when you approve a vaccine is given to like very, very large number of people. So if something goes wrong with that vaccine, a very, very large number of people all over the world will be affected. That's why they just want to make sure 100%, close to 100% that it is safe. That's why it will take a bit longer. But the good thing is that this virus seems to be so far is that its mutation is very slow compared to influenza virus. So if that comes out to be true, that means that his immunity will last longer. So that is the hope. It might last many years or might be even longer. That's the hope so far.
Okay. So there are several attendees who are asking some technical questions. I would request my panelists if you can go to the question answer side and then try to answer some of those technical questions which people are asking. I have several very basic questions which the community members want to know and I want to ask. The question is, the takeout, the restaurant, the food, the groceries when we go, I mean, is it safe to do those type of things? And how can we protect ourselves, especially from takeout?
It's very interesting. The reason why this was done was because of fomite transmission. If you have it on the surface, it can last on the surface for a long time. Can you hear me?
Yes, yes, we can hear you.
Yeah. So it does stay on the fomite. So if there is a takeout, you are at risk. And if you touch your mucous membrane, you are at risk of transmission. The other question that I want to answer, I just saw it on the Q&A was, do they have other symptoms apart from, you get other symptoms? Yes, you do. Actually, you can, not many people are getting GI symptoms. I don't know what is your observation there. A lot of people are getting GI symptoms. And a guy I just saw about a week ago, he told me something very interesting. He was a diabetic guy, well controlled. And when I finished interviewing him, I was about to get out of his room. And he told me, oh, doctor, I think I'm feeling better. I asked him why. He said, oh, my sense of smell has come back. So that was something that when I researched it, I found that there's a lot of taste abnormalities and loss of smell in these people. Very high proportion, actually.
This relates to other questions. Somebody asked, can you have COVID-19 without fever? And one of our physicians, colleagues, had anosmia, and he had read about that anosmia is one of the presenting symptoms for COVID-19, and so he wanted to get tested. We limited testing, so I had to actually advocate for him. He did get tested, he's positive, and we are reading a lot more about that. The other thing about the GI symptoms, the study from China, we had actually a webinar with physicians from Wuhan, and they said they were identifying they have identified in China and other places the virus in the stool samples for a period of time. So we don't know much about it, but I'm sure we're going to learn more. You know, does it cause symptoms there, or it's just there for the ride, or what?
But fecal-oral transmission is not a major.
No, not right now. That's not. But that's what I'm saying. What we don't know is.
Don't know, right?
Yeah, we don't have that information. I don't know. Wes, have you seen the GI symptoms in your experience?
Actually, a lot GI symptom. We have, and the main thing is that people who present with GI symptom, they have more viremia, looks like, because their symptoms otherwise they do pretty bad, actually. We have about 20-30% patients who come and they have GI symptoms.
There's a question online, Harun, which says, what is the turnaround time for COVID-19 in your area? I assume they mean the turnaround time for COVID-19 tests. And first of all, where I am, you just can't go and get the COVID-19 test. And it takes, there's a process for that. It's not available to general public. So you have three really ways, or four, I should say, ways of getting this test done. One is through the Department of Health, with very selected criteria, and they only want to test, the highest risk and such. And so their turnaround time is actually it's quite fast. If you get it to them by 10 o'clock, they'll have the results for us by 5 o'clock that evening. The second test is where we are collaborating with one of the other institutions in town, and if we send our test by a certain time in the day, they will have the results for us by the end of the next day. And then there is your LabCorp and the Quest of the world, where they say the turnaround time is 4 to 5 days. My experience has
I think we got a little disruption. Well, we are almost out of time as well.
A couple of questions I picked up. Should I go ahead? And
I think we are out of time,
okay.
And I want to thank each and every one of you. Thank you, gentlemen, for taking time and answering the questions. We will return next Sunday with new panel, new questions. Thank you very much, everyone. Khuda Hafiz.
Thank you, Dr. Masood and Dr.